The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, everyone. Glad you're here. We're going to talk today about the topic of why we don't need a specialty to treat TMD. I am Tony Urbanek, and this is TMD Demystified. I am going to present a case for literally the removal of the specialty of orofacial pain, which was granted by the ADA in 2022, I believe. I think that is correct. After reviewing how they and why they did that, I can't believe they did that because it doesn't make any sense in comparison to the other specialists and specialties within dentistry, which are necessary to be designated as specialties because parts of the efforts or work in that area of dentistry, some of it requires extensive and particular knowledge that you're not going to learn in the normal channels. So there are multiple specialties within dentistry. The first five were granted in 1947 by the ADA because these particular areas, it was seen, needed extra training to treat the areas of dentistry correctly. And since then, there have been five other specialties granted, which were also appropriate. And then the 11th, which was orofacial pain, was totally inappropriate. And I'll make the case for that, and we'll discuss that. So we're here on Tuesday morning, ready to do my next episode of TMD Demystified. The first five specialties which were designated, if you want to say granted, by the ADA in 1947 were oral and maxillofacial surgery, pedodontics, children's dentistry, periodontics, orthodontics, and prosthodontics. And as any dentist will attest, certain parts of that can get very complicated and can be useful to have significant extra training to understand the science behind it and the clinical efforts needed to get the results in those particular areas. In my area, I could talk about it all day long. Oral and maxillofacial surgery back in 1947 had mostly to do with extractions, impactions. We didn't have dental implants, but oral and maxillofacial surgeons, or oral surgeons as they were called at the time, were called on to do facial fractures. After World War II, or actually during World War II, the dentist had a large part to play with facial trauma. And then from that, the expertise developed on treating the skeletal fractures of the entire face. And 70 years later, the oral and maxillofacial surgeons and oral and maxillofacial surgery are the preeminent specialty in medicine and dentistry that treat facial trauma, rightfully so, because we are honestly the very best at at moving bones around, treating bone fractures of the facial skeleton. And of course, as a board-certified oral and maxillofacial surgeon for 50 years, I had plenty of experience doing trauma to the face. But that was a specialty, oral and maxillofacial, which was definitely appropriate as a specialty in dentistry. However, in 2022, the ADA approved orofacial pain as a separate specialty, and I'm going to tell you exactly why that happened. As those of you who follow me along know that on Sunday night, before my Tuesday podcast, I always write a blog, several pages of blog, on the topic that I'm going to talk about on Tuesday. And so I'd like to read just a couple paragraphs off my blog, which will condense to a point what I have to say. No one group, no business, and certainly no institution of higher learning should control the treatment of any disease. But that is exactly what is going on in 2020. Excuse me, it's 2020, not 2022. In 2020, the American Dental Association, at the behest of the National Commission on Recognition of Dental Specialties and Certifying Boards, an independent agency of the ADA, agreed to make orofacial pain a specialty in dentistry. This was accomplished by a small group of dentist members of the American Academy of Orofacial Pain who held themselves out as having specialized knowledge for treating the disease, while denying what the orthopedic surgeons in the medical profession have known about treating joint disease for a century. This is quite unusual. This is quite an unusual situation in comparison to the other 11 specialties in dentistry. So I'd like to just bring to the viewer's attention the mechanism that actually creates all of the facial, and I say all of the unusual facial pains that the orofacial pain doctors want to make complicated, because this is not a complicated disease if you understand the pathophysiology, or that's the fancy word for mechanism that creates the symptoms. And I've discussed that so many times, but I'm going to bring it out again on this particular day and on this particular topic to make it very clear that we don't need a specialty to treat TMD or other facial pains, because it all comes together when you understand the actual mechanism. So here is a diagram that basically shows the mechanism that has been known to the orthopedic surgeons and my orthopedic colleagues for literally for over 100 years, and has been published in multiple peer-reviewed journals as not a hypothesis, but established physiology of how pain is created after a muscle becomes damaged, after a joint becomes damaged. If a joint is damaged, whether it be hip, knee, elbow, or TMJ, this same mechanism occurs, and it explains how you can get facial pain, which moves around not only on the face, but in the neck and in the shoulders. But the mechanism is this, and if you can see my pointer, hopefully you can, you have a temporomandibular joint that is damaged. There are three causes that damage a joint, the temporomandibular joint. One is bruxism. Everybody knows about bruxism and thinks it's the only cause, which is not. But bruxism is one of the three. Bruxism, too much use of the joint. Bruxing during the day, during the night, or both night and day. Acute trauma episodes. Acute trauma is mostly motor vehicle accidents, but can be sporting accidents, sport accidents, falls, different things that acutely damage the joint. And the third is functional malocclusions. Bad bites, bad position of the jaws, bad jaw growth can cause overloading the joint. What all three of those things have in common is they overload a joint. If you overload a joint, it becomes damaged. If it becomes damaged, it becomes inflamed. And when it becomes inflamed, it sends signals that it's inflamed. It's painful. It trips off the nociceptors in and around the joint, and it sends signals to the brain, in the brain stem, if you can follow my pointer, to the different nuclei in the train of nerves and nuclei within the reticular formation in the brain stem. So first, the signal comes from the joint up the afferent fibers of the autonomic nervous system, sympathetic portion, to stimulate the trigeminal sensory nucleus, which then goes on to stimulate the trigeminal motor nucleus, and then down the spinal trigeminal nucleus to the muscles that move the jaws. Now, the muscles that move the jaws, let me go back so you can see the muscles that move the jaws are inserted in different areas of the face all over the place. And those signals don't always go to the same muscles at the same time during the same time of day. And patients will complain of facial pain wherever those muscles are attached to the facial skeleton. Where the muscles are attached to the facial skeleton is where they stimulate the nociceptors, pain receptors in the periosteum. They pull on the bone, and it creates pain that the patients can perceive as a headache. They can perceive as sinus pain because it hurts here. It's my sinuses. No, it's the muscles pulling on the bone, which creates painful sensations going back to the brain. Back of the neck, sternocleidomastoid. When the inflammation continues, the joint does not heal, the signals continue on, the brain says, I told you, hold the whole jaw still, the muscles of the face hurt. It demands that the whole head be held tight, and the neck muscles get tight, and the patients complain of neck pain, and then it can go into upper back and shoulder pain, and the whole upper shoulder girdle can get tight. That is the mechanism for what used to be considered undiagnosable facial and other pains. TMD, by the way, is not multiple diseases. It's multiple symptoms. You have multiple symptoms. It hurts here, it hurts here, it hurts here. Those are painful symptoms, and TMD is well known to have muscle pain moving around, but it's not the muscles that are hurting. It's where the muscles are getting signals to contract and hold the jaw tight, the whole head tight, and then the whole upper shoulder girdle tight, and the patients will complain of various pains in their own words, of different kinds of headaches, facial pain, neck pain, shoulder pain, upper back and shoulder pain. And when the muscles of the neck get tight, they squeeze the brachial plexus, and patients will even complain of arm, hand, finger tingling and numbness because the nerves, the brachial plexus, the group of nerves coming off of the neck, which control sensation and movement in the arms, hands, and fingers. TMD, multiple symptoms, one cause, inflammation. But getting back to the topic, I'm going to make a case for this. We don't need the specialty of orofacial pain. The doctors who do this can't say they shouldn't treat the patient, but they don't need to be a specialty. That is ridiculous, because treating this problem is actually very easy. You treat it just like the orthopedic surgeons treat a damaged knee if surgery is not warranted. And well, how do they treat a damaged joint, a knee, a hip, an elbow? They rest it. They put it in a sling. They use crutches to unload the joint. And so a device that unloads the temporomandibular joint by unloading the posterior teeth, where 90% of the loads come from. 90% of the loads on these joints come from the posterior teeth. So it stands to reason if you are bruxing day and night, or you already have inflammation from acute trauma, or even if you have functional malocclusion causing the damage to the joint, by unloading the joint according to a protocol long enough and carefully enough, the inflammation will decrease. When the inflammation decreases, these signals will no longer be effective, and the muscles will relax, and the pain will go away. That is the mechanism. That is the mechanism for TMD. But it gets a little deeper than that regarding this new specialty of orofacial pain. So I looked into this very carefully, and so the American Academy of Orofacial Pain are the ones who promoted making themselves a specialty. And here is what the American Academy of Orofacial Pain has to say about their 7 primary tenets, basic tenets, the purpose that they are trying to become, or the tenets that they are using to justify being a specialty. So they have 7 different tenets, and they include, number 1, which I just discussed, temporomandibular joint disorder. They call it temporomandibular joint disorders. They call it disorders because it has multiple symptoms, but I just explained it has a single cause. If you treat the cause, you don't have to treat the symptoms. It demonstrates. This alone demonstrates their total misunderstanding of the disease. So if you have a specialty, a group of doctors who are licensed doctors, dentists, that are treating a disease, and they demonstrate that they do not understand the disease, they should not be qualified as specialists. If they don't understand the disease, they shouldn't even be treating the disease, let alone be designated as specialists. Amazingly. But that is number 1 of the 7 tenets that a tenet is areas of focus that they claim that they are justified being specialists. Their second tenet or area of focus is neuropathic pain. And this is, I'm quoting their literature. I'm not making this up. Their literature, neuropathic pain, like trigeminal neuralgia. Well, let me tell you about trigeminal neuralgia. Trigeminal neuralgia is an archaic word. It actually is a secondary archaic word that was derived from tic de la rue, which was a very archaic word, which went back a couple hundred years, and tic de la rue is a French term, and it basically was the French term for facial pains that were excessive, extreme, and in particular, if you touched a particular area, it would create an excessive amount of pain. Now, there are areas that if you touch, can create an excessive amount of pain. The one that I have seen constantly for 50 years has been if you touch the tip of the coronoid process, which is where the insertion of the big temporalis muscle is. If you have TMD, temporomandibular joint disorder, everyone has a very tender tip of the coronoid process of the mandible. And whether you do it intraorally or you do it extraorally, if you touch that one spot, the patient sometimes will come out of the chair and scream, "Oh my God, that hurts." But neuropathic pain, they use an example of trigeminal neuralgia. Trigeminal neuralgia is a catch-all phrase that has been misused, misunderstood, abused and try to be defined as a special disease, a unique disease. Well, trigeminal neuralgia is nothing more than neuralgia, pain of the areas innervated by the trigeminal nerve. The trigeminal nerve has three areas, the upper, the middle, and the lower, that innervate the entire face. And if you have that mechanism, which I just described, where you get tightening of the muscles, whether they be up here or in the midface or the lower face, you're going to create pain. But it's not a unique disease. And trigeminal neuralgia is actually just a catch-all phrase that the specialists are trying to make a separate disease. It's not a separate disease. The next, number 3, is neurovascular pain. Now that, again, is a descriptive term, neurovascular. It is pain associated with the nervous system, which is associated with the vascular system. Now that term goes back a long way in scientific research that goes back into the 1970s and 80s by doctors who were studying migraine headaches. And as they say in their tenet, area of interest, neurovascular pain like migraine headaches, like migraines. If you investigate the science behind migraine headaches, there is no one who claims they know what causes migraine headaches. Every scientific article, peer-reviewed or not, will admit they don't know what causes migraine headaches. They do have some theories behind it. And one of the theories that they had in the 70s and 80s was that it was associated with the neurovascular system. Well, guess what follows the neurovascular system, or what follows the vascular system, is the autonomic nervous system sympathetic portion. Follows the vascular system and also has major effects on the vascular system. Blood vessels constrict and dilate relatively tremendously, by the effects of the autonomic nervous system sympathetic portion under duress of various kinds. Anxiety, worry, stress, trauma will cause the autonomic nervous system to trigger and cause the vessels to constrict or dilate, depending on circumstances. But it's not a separate disease. It's a mechanism of how the body works. But again, our specialists in orofacial pain want to use incomplete science, untested science, science that admits they don't know what causes migraine headaches, to justify being a specialist. Doesn't work. Doesn't work. In my investigation, by the way, migraine headaches, I am not saying there is no such thing as a migraine headache. We know, however, that thousands of patients, hundreds of thousands, if not millions of patients, have bad headaches that come and go. My medical colleagues use medication. Basically, they use all kind of medication, but what all those medications do, what they all have in common, is suppressing the nervous system one way or another. Suppressing the nervous system. You're not suppressing the nervous system of the face. You're suppressing the entire nervous system of the body with various drugs at various times. And this is the way I describe it, and I stick by it. They throw drugs at the wall to see which one's going to stick, which one's going to suppress the nervous system enough to suppress the pain coming from the face or the neck. So, but again, no one knows what causes migraines, but we do know what causes TMD headaches, which I've explained thoroughly. Excuse me. So, this is the second tenet, and in my investigation, I wanted to see, well, what's the most frequently used drug? And I came across a very recent drug approved by the FDA that literally suppresses the transmission of nerve signals between one nerve to another throughout the body. And of course, this is anytime you take a drug, it's nothing more than a series of side effects. And the doctor says, this is the side effect that we're taking this drug for. What he usually does not say is the other side effects you also have to take along with them. You will get this happening as the purpose of the drug, and all the side effects you're going to have to deal with also, because drugs are nothing more than a series of side effects. But the most recent one was a drug which I will leave unnamed, but you can look it up. It comes across as $100 per tablet, $1,000 for 10 tablets, and the drug company that promotes it specifies that you can't take more than 10 tablets a month because of the severe side effects possible of overloading yourself with this drug that totally limits the transmission of nervous signals from one nerve to another. So, an orofacial pain specialist who uses drugs does not have to be a specialist to use drugs, for sure. And definitely you have to be cautious when you do. And the fourth tenet they call muscular pain and dysfunction. Well, obviously, I described for you what's happening when the muscles get signals to get tight. They are protecting this joint, this temporomandibular joint. The same mechanism, though, works on hips, knees, and elbows. If you have a damaged elbow from too much tennis, the joint becomes inflamed. It's the forearm that hurts. Painful forearm is tennis elbow because it's the muscles in the forearm that move the elbow. The brain stem, the brain sends signals down, don't move the elbow, I'm going to protect the elbow, don't move the elbow, and you get pain in your forearm. When you have temporomandibular joint pain, inflammation, chronic inflammation, the signals come down, I'm going to protect the temporomandibular joint, don't move the joint, tighten up the jaw muscles, then tighten up the neck muscles, tighten up. We got to protect this joint. But they claim by their own statement that muscular pain, you have to be a specialist to understand muscular pain and dysfunction. There is no dysfunction. The muscles are functioning absolutely correctly. They are becoming tight at the signals from the brainstem to protect the joint. You don't have to be a specialist to know this. In fact, it's very simple. Pathophysiology is very simple physiology. And every dentist went through basic sciences and was exposed to, whether they remember it or not is a different story, but were exposed to this information. Number 5 in their tenet list was primary headaches. Now, primary headaches, again, is a catch-all phrase, but they use it as justification. But the definition of primary headaches is as follows. Primary headaches is another catch-all phrase that by definition includes migraine headaches, which I've already discussed, tension headaches. We know that anxiety, worry cause headaches. Why do they cause headaches? Because the only mechanism that we know that we can say with authority about clenching and grinding bruxism, it is related to anxiety, stress. And when you are stressed or anxious, you clench or grind, And if you already have inflammation within the temporomandibular joint, it will trigger those nociceptors, which puts that entire mechanism in play. And then you will get muscles tightening, trying to protect the joint, and you have a tension headache. Very simple. You don't need to be a specialist. But it also includes cluster headaches, which are cyclical. Definition of a cluster headache is a cyclical headache. Well, yes, these TMD is a cyclical problem, for sure. So again, their stated tenets, primary headaches, are actually just a combination of misunderstanding of the mechanism that is going on, or not understanding it at all, or just plain word salad, trying to play on words that don't have decent definitions, that don't have a real meaning. The sixth is atypical dental pain, and that I can explain very, very easily. Dental pain what dentists refer to as dental pain, is easy to diagnose. A dental pain. Dental pain can come from exposure to the nerve within a tooth from decay, very common, or periodontal pain, pain associated with the tissue around the tooth. That is dental pain, and any dentist can absolutely be qualified and knowledgeable how to distinguish between those two and whether they have decay pain or periodontal pain. But if you have a tooth that the patient says it hurts, and the doctor looks at it and he goes, there is no decay here, and there is no periodontal problem here. I don't know what's going on, but this is not dental pain. Well, that is called atypical dental pain. In other words, patient says it hurts, but it's not dental pain. Well, I can tell you that by experience, I have seen literally hundreds of patients who come in and have talked to dentists into taking out a tooth or two, occasionally three, because they say this tooth hurts. And the doctor says, I can't find any reason why that tooth should be hurting. He says, no, I want you to take out the tooth because it hurts. Well, a good dentist won't do that. He will say, no, I'm sorry, I don't have a reason to take out the tooth. But some patients are so insistent, or the doctor, for whatever his reasons are, gives up and says, okay, I'll take your tooth out. And they come in with a few missing teeth with the story that a dentist took the teeth out, but the pain was generated by the muscles over that area where the tooth is on the bone. It can be upper jaw, it can be lower jaw. Almost always it's a posterior tooth, almost always. In fact, I can't recall an anterior tooth having this story go along with it. Patient would come in with obvious temporomandibular joint inflammation. Proper definition of TMD should be inflammation of the temporomandibular joint. Obvious TMD symptoms: the joint is painful to push on, they have all the other symptoms associated with it, and a few missing teeth that they talked the dentist into removing, and the pain was generated by the muscles over that area, in that area of those teeth, pulling on the bone that supported that tooth, and the patient called it dental pain, unknowingly, inappropriately, and the dentist took out the tooth. Again, you do not have to be a specialist to know this and apply that knowledge. It isn't complicated. And then the last, and we'll finish this up, which I found extremely stunning that they even included it, is the psychological aspects of pain. You don't have to be a doctor. You definitely don't have to be a dentist. You don't have to be a physician to understand that pain creates psychological stress to a person. All that you have to do is have a little empathy when someone is in extreme pain or moderate pain, and understand that pain can cause a person's personality to change, or the way they interact with society to change, or the way they interact with the healthcare provider to change or be difficult. all that's necessary is you to develop a little sense of empathy. You definitely aren't going to talk somebody out of their bruxism, their anxiety. We all know that I just learned or read an article where literally half the population is on some kind of anti-anxiety drug. Everyone has stress on this planet. Everybody. Some people handle it well, some people handle it poorly, some people get on the slippery slope of taking drugs, street drugs, prescription drugs. It's a very slippery slope. But to be a specialist in orofacial pain, you don't need to know much about how to handle patients with anxiety and in the anxiety associated with pain of the head and neck. You just have to have a little bit of empathy for these patients. So to top it off, I'd like to just share one more slide to make the point. This is not new stuff. What I have to say, what I just said, is the reflex muscle splinting of the joint, any joint, including temporomandibular joint, which is established physiology. And I did a little research with the help of AI, and the foundational neurophysiology was first identified and published by a Dr. C.S. Sherrington, the integrative action of the nervous system at the University, Yale University Press in 1906. And then skipping ahead decades, all of this same splinting physiology, basically the brain's attempt to help a joint heal and protect the joint, its protective mechanism, is seen in the orthopedic literature in 1997 under author's name Hurley, and Hopkins, separate in the Journal of Sport Rehabilitation in 2000. Then you skip over to the trigeminal and TMJ neurophysics. B.J. Cecil had an article on this in the Journal of Oral Rehabilitation in 2006. And again, Cecil in the Journal of Orofacial Pain in 2004. So there's a journal on orofacial pain where Dr. Cecil explains the reflex muscle splinting mechanism, which totally explains all of these odd and disparate symptoms of pain in and around the head and neck, which again, any dentist can see, and you don't need to be a specialist to understand this mechanism. This single mechanism explains it all. And then finally, the TMJ specific reflex evidence from Drs. Wang and Arndt Nielsen, again in the Journal of Orofacial Pain in 2004. This mechanism is very simple to understand. Every dentist should be exposed to it. Every dentist should know it. It's not hard to teach. It's not hard to understand. And you definitely don't need a specialist and a specialty service to use it and provide it. All right, with that being said, I'll wrap it up. I'll encourage anyone who would like to know how to treat temporomandibular joint disease correctly using a device and protocol that unloads the temporomandibular joint. You can learn about it at www.urbanektmj.com. For those doctors who'd like to do that, you can take our course. It's a 3-hour online training course where you can learn the mechanism, which I just spelled out, and a few other nuances of using this device, which unloads the temporomandibular joint like a set of crutches unloads the knee, or a sling unloads a tennis elbow, Again, at Urbanek TMJ, excuse me, at www.urbanektmj.com. Anyone who'd like to communicate with me, I am available. You can reach me at tony@tmjservices.net. With that said, I look forward to the next topic I'll choose for next Tuesday. I am Tony Urbanek, and this is TMD Demystified.